So let's look at one more here. So Mike from Georgia writes in and says, in your practice, which blocks are the most rare and most common? I would say I work in an orthopedic only hospital right now. So the most rare blocks that we do, which are kind of not falling out of favor, but they're sort of anachronistic in that they're not done that much anymore, would be an axillary nerve block up here where we block the brachial plexus in the axillary area, and femoral nerve block, which femoral nerve blocks used to be very, very common. But because of the quad weakness that we get from that, surgeons tend to not want the femoral nerve block anymore. So I would say we're not doing a lot of axillary blocks because the supraclavicular block is a little bit superior in my opinion, and I think most folks' opinion. The infraclavicular gives you some advantages over the axillary block. I typically do the axillary block when I have someone with some lung disease and I want to 100% avoid a phrenic nerve block so I don't go above the clavicle. Or if I'm doing elbow surgery, you get some advantages with an axillary nerve block. You can go and get the intercostal brachial nerve with an axillary nerve block for elbow surgery, so that can be helpful. The femoral nerve block, I pretty much take it and use it when we're doing some sort of amputation on the lower leg, whether it be a below the knee amputation or above the knee amputation. It is my opinion that every amputation deserves to have a femoral nerve block and a sciatic nerve block, because you decrease the chances of chronic limb pain and phantom limb pain from roughly around the mid-30s, 35, 37% down into the single digits if you do single shot femoral and single shot sciatics. And if you put catheters in and infuse those catheters for several days, you can take that phantom and chronic limb pain down to close to zero. Those are probably the rarest blocks that I do in my practice. As far as the most common blocks in my practice, being orthopedics, would be adductor canal blocks, supraclavicular blocks, infraclavicular blocks, interscalene blocks, PENG blocks, lateral femoral cutaneous, anything that is involved with regional anesthesia for orthopedic procedures. Now, in people that work in multi-service hospitals, I think TAP blocks, erector spinae blocks, QL blocks, and all the blocks that I mentioned for the orthopedic stuff is very much common these days. And as our population ages and we have 10 to 12,000 baby boomers every day are retiring, which is an amazing statistic that I ran across not too long ago. And I found it hard to believe, but I've heard it from several sources, so I suppose it's true. With that many people aging and coming into the medical consumer marketplace, I guess you'd call it, they're all going to need nerve blocks because they're going to need total knees, they're going to need total hips, total shoulders, they're going to fall and break bones. There's just more people in the medical industry marketplace. So as that happens, the workforce has to kind of bone up on these things. So I think you're going to see nurse anesthetists being much more involved in pain control for these patient populations.